First of all, thank you for coming. I would like to introduce Dr. Lukan Mishev for coming to give a presentation on CANON and on the OCT A1. And we're happy for you to be here. So I'll give you the mic and you can start.
Thank you, Ori. Thank you for the invitation to be here. Dear colleagues, I will speak about the everyday use of CANON Xephilio A1 OCT. Thank you. So, these are my disclosure regarding the presentation. And this is the first case that I will present. It is a PAM after silicone oil removal. It's a situation which is really devastating, especially for the expectations of the patient. And without such level of resolution, we cannot be certain that this is the diagnosis, and we might not have explanation about why the patient doesn't see. And vice versa, when we see and we can show where is the problem, here obviously is the absence of the plexiform layer. We can point a reason why the patient doesn't see. This is another imaging modality on the same patient, and the coronary scan or the end-phase imaging show the wrinkle where the ischemic event has occurred. So this is something which is not related to the surgeon or the surgery, and it is important to be able to explain why the patient doesn't see. Another example of how we can identify the area of affection and where the problem exists, even with the octa. And this is the follow-up imaging. Unfortunately, this is permanent condition which cannot be spontaneously resolved, or there is no proven therapy for that. Again, you can see the area where there is absence of perfusion already. And another example of end-phase scanning with the CANON machine. So, another similar condition, acute macular neurotrophy after silicone removal. Again, something which we might experience as vitreoretinal surgeons, and it's really devastating. Again, we can pinpoint the area of the incident, and this can explain the scotoma that the patient sees. Another thing that is quite useful when on the first day we need to show to the patient what is the result of our retinal detachment surgery. In this case, this is a silicone-filled eye, and we can show really well the layers and the shape of the macula and the silicone line and the type of the tamponade. We perceive the name CANON as image. So you can see that the image quality on this OCT is actually remarkable. So CANON relates to a good imaging in my mind. This is another example of silicone-filled eye, and we can appreciate the reflections of the contact of the silicone with the retina. This is also imaging of this problem of the inner plexiform layer where the ischemic incidents occur. So if you don't have enough resolution and if you don't have enough image quality, you might miss the reason of why you have a suboptimal outcome of your vitreoretinal procedure. Again, a vascular incident, the AMN. Also similar condition. And these are different types of depicting the result. Here is a color coding. Obviously, it's a false color coding, but it can pinpoint the area of the problem, which is more easily understandable for the patient. This is another imaging modality which we really love in our clinics, because we are able to image macular hole surgery on the first postoperative day post-operative day through gas. This is something which I wasn't able to achieve with any other machine until we bought our CANON OCT. So here it's obviously gas-filled eye, and on the first day we can show to the patient your surgery is successful because you have a closed macular hole. Otherwise, he needs to anticipate the result at least 10 days until the gas resolves. So it's another unique feature of this OCT. This is a coronary scan or M-phase scan plus Opta of a technique called temporal ELM flap for closing the macular hole. So we can really appreciate with high level of resolution and details how our flap sits after the surgery, not how we place it during the surgery, but what is the evolution of the flap and the anatomy of the macula. A larger image of this M-phase scan. Another case of full thickness macular hole, again imaging through gas. As I said, really important and really useful for the patients and for us also actually to adjust if we need our surgical technique as soon as possible. This is a case of ILM envelope technique where we are using heavy silicone tamponade, and this is a re-operation of an unsuccessful closure of a huge macular hole. So in order to be sure, we use the envelope with heavy silicone. And again, the higher resolution images are quite useful for us in order to even predict the prognosis of the patient. Another case of full thickness macular hole with temporal ILM flap. I want to stress that the anatomy of the closure is really amazing. If you look only the right images, you might not guess that there was a surgery in that eye. But again, when we have enough resolution, we can appreciate more the details of what we have done during the surgery. This is a case with a temporal ILM flap, but different fashion of flap. It is multi-layered flap, and obviously one of the flaps is actually not covering the nasal side, but fortunately the hole is in the middle and it is well covered and the macular hole is closed. Again, the same image. The beauty of the M-phase scan is that we can do a custom layering and we can adjust the thickness of the slab. So we can highlight the tissues that we want to see, and the density of the scan allows us to fly through the retina with enough resolution. So on every layer of the retina where we have interest, we might see what we want to find there. A lot of macular holes, but obviously this is part of the job of the vitreoretinal surgeon. This is a macular hole with a temporal ILM flap, and this is the view on the first post-operative day. What do you think? Is this a successful surgery or it might lead to a failure? The only answer is that we need to do a follow-up. From the literature we know that the ILM flap tends to progress slowly and close the macular hole slowly in some patients where the cystic changes show that it was long-standing macular hole. So this should be the follow-up image on the same patient, and you can see that a week after the first image, the closure begins to form, and the patient function is already 0.6 here, and you can see some of the flap which is there. So again, CANON means high resolution image. This is example of preretinal hemorrhage. So the patient was with a retinal macro aneurysm, And what I want to show is the penetration, and through the blood we still might see some details of the retinal morphology, which means that the algorithm which determines if this is a useful image or not is quite robust. And albeit the low level of the signal, it still can distinguish between the blood, lack of signal, and the retinal morphology, meaning that the image is correct anatomically. This is another image of the same condition, obviously after a treatment. The interesting thing is that this patient got treated with Vabysmo, which actually led to resolution of this condition, and the follow-up of the patient shows the amazing imaging capabilities of the machine. This is another case of retinal detachment where it is important to find the detached macula, because sometimes we have retinal detachment with macular fall. Why it is difficult for the other machines? The window of acquisition as a length sometimes is smaller. So here I want to stress your attention. Where is the pigment epithelium? Where is the macula? And where is the vitreous body? So the windows of acquisition is really large, which is useful for the everyday practice. We got more useful images. Another case of retinal detachment, obviously preoperatively, and this is imaging through gas. So not only macular holes, but in retinal detachments which were treated with gas tamponade can be seen on the first day with OCT without any posturing and without any fancy attachments on the OCT in order to achieve imaging through gas. This is another case of retinal autograft, and you can appreciate again the quality of the image. You can appreciate the wrinkles in the pigment epithelium, meaning that this eye is with hypotony at the moment, and we can see the follow-up later on, but still we can see where the flap is seated with really good image quality. This is the M-phase image of, this is the infrared image of the flap over the retina. This is the Opta over such anatomically non-correct situation. And still, it's interesting that vessels are identified in the flap. The only drawback is that they are identified, but we don't know if they are perfused or not. So again, Opta is quite useful, but without the functional component of the diagnosis. And this is interesting case. Anterior segment is not a vitreoretinal pathology, but this is a case of chemical burn, and it shows really well the structures of the cornea and where is the penetration of the chemical agent, where is the lack of epithelium, where is and how the Baumann membrane is behaving, how the Descemet membrane is behaving. The chemical burn was with not with acid, but with bases, meaning that the pH was 7, 8, 9. We know that this is some condition which is really dangerous, and we cannot stop the necrosis at the moment, and it requires further treatment. Again, what is useful? Epithelium thickness maps and corneal thickness maps. Why they are useful? Because they can show if we are on the right direction with our treatment or we are losing the battle with the necrosis. Because we can see that after the treatment and our attempts and efforts to save this eye, we have a reduction of the thickness, meaning that the cornea returns to normal function. And this is how we started, and this is how we finish. So thank you very much for the attention, and I'm open for questions if there are any.